talk. Good morning, Commissioner Sullivan, and thank you for attending the meeting today. I've done a little basic math that I'm happy to share with you after the hearing. But what it looks like to me is that the $110,000 that is supposed to be reinvested in the community per bed reduction is actually $41,250. If you multiply that by 200 beds that we're losing, it comes up to over $13 million. And I don't think, I'd like to know where that money is going. And I looked through the all of our budget books, and I looked at the closures versus where the money is going, and the math doesn't add up to me.
Oh, thank you. The reinvestment dollars for this year total $16.5 million. That's what's going to be put into the reinvestment for the closure of 200 beds. Now, 100 of those beds will be getting the full reinvestment of $110,000 into community-based services, so that's approximately about $11 million. The other 100 beds are individuals who have been in our state hospital system, but who truly need nursing home care, and they really should be in a less restricted environment than a hospital, and really in a nursing home. We, in terms of transitioning our population to those nursing homes, we will need to establish with the nursing homes policies and procedures and additional staff to work with them. That staff is included in half of the reinvestment dollars. So that would be $55,000 will go towards those teams working with our 100 individuals in the nursing homes. So to be absolutely transparent, we wanted to be clear that we didn't consider that to be community-based services. So of those 100 beds, the other $55,000 does go to direct community-based services. That's about $5 million. So for the 200 beds, there is a reinvestment allocated of $16.5 million. You are correct that a portion of that, about $55,000 per 100 beds going to the nursing homes, will be for teams to work with the nursing homes. So that's the way the money is being allocated.
Now, do you have buy-in from nursing homes? Are these going to be county nursing homes or just non-for-profits?
No, not-for-profit. Whatever nursing homes are local and in the areas where our patients want to be and where their families are. So we'll be working with a variety of nursing homes across the state.
My other question is about the training. These are folks that have been in facilities for a very, very long time. And this is a geriatric community. Sometimes we talk about placement of people with disabilities in long-term care. How do we feel that this placement is appropriate for somebody with a long history of mental health that probably, I don't know whether the staffing is very specialized, to be specialized in mental health issues, anxiety disorders, and all of those kinds of things. How are we going to train the staff to give appropriate care to these aging individuals? And are they really geriatric patients, or are they young people that have just spent a lot of time in a mental health facility?
No, these are, by and large, they are aging individuals who now have considerably complex medical problems, which really can be well served in a nursing home population. And that's why we have these teams. They will not just work with the clients, they will work with the nursing homes to provide the training, just as you said, quite appropriately, for nursing home staff to be able to understand how to work with our clients. I think that often that training isn't there in the nursing homes, and that's why these teams will be very tightly wound around these individuals going to the nursing homes and doing that training.
So how is moving a person from one place to another reinvesting? Like, in other words, if you have a person moving from, as an inpatient, from a psychiatric center to a long-term facility, what is the benefit, and where's the savings, or is there savings, or what is the intention of it?
Yeah. The intention is to really provide a better setting for these individuals. We really feel that because of the medical issues that they have and the kind of care that's in a nursing home, that they would be better served clinically. That's number one. Number two, that's why we're not assigning the full community reinvestment to these beds, but we are setting up these teams to work with the clients in the nursing homes. When we also downsize these beds, it's by eliminating a bed, for example, that is occupied all year long with one person, we then open up the availability for other community-based individuals to come into the state psychiatric centers because of the turnover phenomenon, the number of admissions you can actually have. So we will be able to even better serve some of the acute needs of the communities with lesser beds, with fewer beds.
So another commitment that was made to the legislature and to the provider community was a $120 million commitment to a BHO HARP investment. Almost immediately, that commitment was reduced to $115 million. Why is that?
That was reduced as a budget accommodation, I believe, last year. So this year we have been working with the number of $115 million. That $5 million was decreased last year.
Okay, I'm going to come back again.
No, you can go, you can go to 10 minutes, keep going.
Okay. You look at the $40 million for community service, $20 million for BHO, okay, I'm just looking, I think that's it for now.
Thank you, thank you.